You are the session that you're in now is VA Suicide Prevention 2.0 from the clinic to the community, and our presenter is Justin Fienhold. He is the Suicide Prevention Coordinator for VA Pacific Islands. So I'm going to go ahead and turn it over to him, and he can start his presentation. Welcome, Justin.
Well, thank you all for having me today. The presentation today is called Suicide Prevention 2.0 from the clinic to the community. And as you know, as Andy introduced me, I'm the Suicide Prevention Coordinator for the VA Pacific Island Healthcare System. Just to kind of give you an idea of who we are and what we do, we are a team of 5. There is myself, I'm an LCSW, and I have 2 other LCSWs that are suicide prevention case managers. They really assist in a lot of the clinical matters that we do. We also have a peer specialist and a PSA on our team as well. So we have 5 of us strong, very small team covering a multitude of issues around suicide prevention throughout the Pacific Island region. Just a couple things about what we do. We provide a full continuum of care, which means we do operate from a prevention to a clinical standpoint. On the clinical side, we're really assisting in tracking and reporting a mechanism in the VA for high-risk flagged veterans. Excuse me. We also respond to veteran crisis line consults on a daily basis, which I'll actually share a little bit about later. That's a big part of what we do. We train and educate our VA stakeholders within the VA as well as our community stakeholders. So we also get out to the community and do outreach. We're on a number of task force throughout the state and island chain. So as you can tell, there's a lot going on with our program and what we do. And that's just a tip of the iceberg as well. But just to get you all kind of familiar with what we do. So today as we get started, these are always unique doing presentations without being face-to-face. I know Andy's going to help me out with any questions that may come about. From time to time, though, I will pause, though, just to have you think about the questions. So I know that we don't have a mechanism maybe for interacting as much or hearing your voice. However, whenever I call to pause, it'd mostly just be to think about a question. And that question or that thought that you may have may turn into a Q&A that we can address as we move along as well. So what's on the agenda today? Well, we're going to talk about statistics around suicide to get us started in a few minutes. We'll go over what #Be There is, and then we'll talk about some strategies to prevent veteran suicide. And then we'll kind of from there pivot into lethal means reduction discussion and what that looks like. And then really just kind of rounding out talking about this move to the full public health model, which really we've already essentially moved into it. So it's just an ever-growing process of really capturing the full public health approach when it comes to suicide prevention. And from time to time, this will relate to our, specifically to our homeless population, but I wanted to give a big overview as those 2 issues with suicide prevention and homeless do intertwine often within our statistics. First off, just want to go over some data around suicide in the US. And if you look at the bar on the left there in kind of that pinkish red, we're looking at, you know, suicide is really a national public health problem throughout our country. Typically on a given year, especially over the last few years, we're seeing about 45,000 Americans die by suicide, and that figure came from 2017. Among this statistic was over 6,000 veterans died by suicide in 2017. And keep in mind, you know, we're a country of what, 330 plus million people, and our veterans make up less than 20 million of that population. So it can kind of give you just a snapshot of what that might look like with our veteran population as compared to our regular civilian population. In terms of service members and veteran issues, you know, in 2017, the suicide rate for veteran was about 1.5 times the rate of our non-veteran adult population. So a significant impact with veterans and suicide. And then who's at risk here in terms of our veteran population? Well, we know that just statistically in general, whether it be a veteran or a civilian, but our younger veterans, are at greater risk than other veteran populations. Our female veterans are at significant risk. We'll talk a little bit about that in a bit. We also know that veterans that are in a period of transition, research has shown that our veterans in their first 3 months of getting out of the military are some of the most vulnerable periods of their life whenever they are leaving the military. So they're leaving a very, structured environment. Um, and the veterans talk about this a lot where they've got ongoing support. There's people looking after them, checking in with them. And then when they become a civilian, it's often a very daunting move for them to move into civilian life and not have that system that is built in, that network of peer supports and colleagues and so on and so forth. So it's a very vulnerable period for our veterans. And veterans with exposure to suicide are of great risk as well, meaning that they may have experienced a battle buddy, or if they were in combat and lost a fellow service member, that died by suicide in those contexts. And then we also know veterans with access to lethal means are of greater risk. Um, we're not indicating that firearms are a negative thing here. It's just letting you all know that when veterans have access to lethal means, they are at greater risk. And again, we'll cover some of that today as well. Actually, just let me pause for a minute as we move into this next slide and just kind of think about those statistics. I'll move our slides backwards and just kind of pause on, just think to yourself about what comes to mind when you hear those statistics and you read them across the screen. Um, just think internally about what that means to you when you see those statistics. When I do this, I use some of these statistics in a different presentation. And when I have a face-to-face forum, I hear things like just tragic, um, it's too many folks, sad. So you hear a lot of different reactions. People just are really caught off guard by the magnitude of how suicide is affecting our veteran population and as well as our civilians in general. So you can see in this graph here, what we're looking at, there's two different lines here. There's one going through your screen at the kind of midway, starting in 2005, going up to 2017, where our last statistics were formally gathered within the VA for our veterans. But that darker blue line is just the general population, and that's covering all um, suicides in general. And you can see that there's a significant increase from 2005 to 2017 just in general, with a 43% increase. And we can see that there's been a slow but steady increase, and there's been some bumps where actually it increased above that 6,139 that we see in 2017. So that we know that through the VA we've been putting in several different measures to address that. In 2007, the Veteran Crisis Line was created. Along that same time, 2007, 2008, the suicide prevention program was developed. And so with that, the VA has worked on building several different measures to kind of, you could say, combat this issue with veteran suicide. However, we still are above that 2005 level and want to keep working to bring those numbers down. Is our overarching goal is to really decrease the amount of suicides that are occurring each year among our veteran population. And one of the reasons, I don't think I have a slide on this, one of the things that we know about veteran suicide is that the vast majority of veteran suicides do exist, are veterans that are outside of the veteran healthcare system. In fact, around 2014-15, there was a statistic that stated that approximately 20 veterans were dying per day of suicide, and 14 out of those 20 were not receiving VHA care. So just want to keep that in mind. I'm going to start timing myself here because I can get carried away with certain thoughts that come about. So looks like we're doing good on time. So we want to talk a little bit about suicide rates, among our homeless veterans for a moment as well. So if you look at the general veteran population, they have a suicide rate of about 35 per 100,000. If you look to the right there in that blue circle, you can see that our homeless veterans have a much higher rate of suicide of 81 per 100,000. So that tells us that 2 to 3 times more veterans are dying if they're homeless or about to become homeless versus our veterans who are in more stable living or stable housing, if you will. And again, I'm going to follow up with some of that as well through some research here. And there's a recent study I read regarding this, and there's some implications from veteran homelessness. And what the research paper found was that the findings indicated that suicidality peaks just before homeless rather than after being homeless. So it's really interesting that, and you're probably wondering when does that occur? Like, when does this peak time period occur with our veterans that are about to become homeless? And it says there in that kind of teal color that this acceleration of suicidal behavior occurred in the 8 weeks prior to the onset of becoming or being homeless. So I think that also makes us ponder too, why would that be? Wonder what would make that suicidal behavior increase during this time leading up to their homeless period rather than after they are homeless. That was a little bit surprising to me when I read that. And I think that the findings suggest a few things here. If you can imagine one that's not listed here, is certainly thinking about the potential, loss and of feeling, without some hope, without feeling security, um, are likely coming about because most people know that homelessness is coming. Maybe they lost a job, they don't have enough money to pay rent, and they know they're kind of getting at the end of what they're able to manage financially to keep going. So the findings suggested the following: that sudden loss of housing can add to suicide risk. Um, it was a disruptive experience for the veteran in general, and it may increase the shame and fear and hopelessness just knowing that they're going to become homeless. And I come from a mental health background of working, and certainly knowing that um, that's going to increase anxiety, that's going to increase depression, which all raise risk factors for suicidal behavior. And last, we know that any homeless experience within a year period causes a 9% rise in suicidality. So nearly 10% in thinking about that. So we know just homelessness in general does factor into increase in suicidal behavior. But certainly, I think it tells us from this that stability, having resources and support are of the utmost importance for our veterans. Let me pivot, and it's not going to be all statistics, just so you know, but just to pivot to a few other things to kind of conceptualize this and put it into perspective. And going backwards, we were talking about our female veterans being vulnerable. They have about a 2.2 times higher rate of suicide. We talked about our young populations having the highest rate of suicide and being the most vulnerable, but we can't also discount the risk among our older veterans. 55 and older have the highest count, but they also have a higher population count of veterans. And I'm going to get to that last statistic in the coming slides when we talk about that 69% of all veteran suicide deaths results in a firearm injury. Now, this part that we're going to be leading into to pivot sort of into lethal means discussion in a moment is really important for anyone playing a role in the community. You may work at a shelter on this forum. You may be working for a nonprofit. You may be a veteran of some capacity, tuning in right now. And we really want to think about the different parts of the full public health approach. And that's really, taking all of the arms together, or if you think about a tree and the different branches, we really want to connect all the branches to getting to that full public health approach so that we're really addressing the whole picture for the veteran. And we're doing this as a community, not just as the VA. And that's something I really should emphasize, is that really we want to make suicide prevention all of our responsibility. Because the VA cannot, you can think about our team, a team of 5 dealing with suicide prevention. We have over 34,000 veterans in our catchment area. We can't imagine possibly address every suicide prevention need. So that doesn't mean we all have the same roles, by the way. We all do have different roles, and I'll talk just about roles that we can play in a minute as well. But I do want to draw attention to a couple statistics here that I think are relevant to our discussion. If you look up here at the firearm piece here with male veterans, and then also within our female veterans, they're at higher risk than regular civilian male and female non-veterans when you look at firearms. Um, and also with our female veterans in general, compared to our male veterans, are more likely to die by suicide through poisoning. But firearms being the most important here, mostly because it's also the most lethal. And that's why we want to really pay attention to firearms, not to discount or discredit, because we do want to take action towards limiting risk with medications, certainly important in risk mitigation, but just kind of paying attention right now to the importance of firearm safety, and how do we safely limit risk around firearms. So why do I make firearms such a big deal? Well, not only did the statistics tell us a lot about that, and again, I grew up in the country. I am not speaking against firearms for the sake of being against firearms. It's more about addressing the vulnerability. I grew up in the country on a farm, hunted, so I have that certain background of I guess you'd say affinity, or just being a sportsman growing up and as a young adult. So I certainly respect how firearms are used and used safely, but it's more about in this context is paying attention to where things are vulnerable when it comes to firearms. And here's just a snapshot of why suicidal behavior has a level of impulsiveness to us, or to it, I should say. Um, if you look at the circles on your left, where it says less than 5 minutes, and that is meaning that less than 5 minutes, a person is considering to make an attempt does so in that time period 24% of the time. So 24%, I should say, 24% of the attempters are making that decision within 5 minutes. That's a quarter of all suicide attempts. Why is that alarming? Well, it tells us how impulsive this behavior can be. We also know that nearly 50% of the attempters did so within 20 minutes, and then 71% did within an hour. That's the vast majority of the suicide attempts are occurring within an hour. So it also tells us that time is important. It also tells us that how we can limit means is really important, because if we give the veteran time to think through that decision and they don't have access in that moment to certain means, then that can actually save a life. And that's why firearms is really an important part of this discussion. And how do we help that veteran who may be in a vulnerable state? If you look to the right there, you see that to the far right, that 5% of all other combined methods end up in fatality, poisoning, jumping, um, suffocation, so on and so forth, versus, excuse me, almost 90% of firearm injuries end up being fatal. So that's why firearms are such a hot topic around limiting means. So what are we doing about it? First of all, the VA is addressing some short-term strategies to mitigate risk, to increase our knowledge and awareness. And one of the things I'm doing within the VA especially, and with the vet centers, is talking about safety planning and lethal means safeties. That's securing firearms, medications, and other items to save lives. Just really educating providers so that they know how to support their veterans, how they know how to engage in the discussion. This is not a discussion about taking firearms away, but about creating a safe, or I mean, a dialogue around safety, around firearms. And if that's a choice that a veteran makes to secure that firearm, and we'll talk again about that in the last part of the presentation of how they can do that, if that's something they choose to do, we can talk about that as well. The second strategy, caring for veterans in our specific medical population. So we're doing screenings. The VA in the last couple of years is creating a screening process where we screen, assess, and do follow-up with veterans that are more vulnerable, that have higher risk behaviors, if you will. The third strategy, reaching out to our veterans to re-engage. Part of our outreach strategy for suicide prevention is to talk to the community about veterans, and we'll have veterans that may have been in VHA care before but have dropped out. We want to support re-engaging those veterans into care again. The fourth strategy there is just our program enhancement. That's really looking at all the resources and tools, our safety planning. We have several newer in the last 2 or 3 years of analytical tools that help us. There's no tool that will predict suicide, by the way, but certain tools will generate higher risk, will show higher risk for veterans based on certain symptoms, medical conditions, and so on and so forth. So we have more tools at our disposal to use that can help implement strategies around that veteran to support them. And that's a good thing for our veteran to really receive robust care. And the strategy 5 there is just reaching all of our veterans through campaigning and through positive messages. That's where #BeThere comes in, and explaining to folks what that really means to our community. And really #BeThere is simply being there for our veterans, befriending them, helping them to be connected to resources in the community. And that's also capturing a whole health approach and also the full public health model as well. So what are roles that we all play? So given where you may work, whether if you're not in the VA and you're joining in and you're in the community, we all have a role to play, as I just mentioned. And that being there is really important, because we know statistically that when a person, or excuse me, a veteran has a significant person in their life, whether it be a friend, a loved one, a spouse, a caring therapist or provider, we know that they're less likely, significantly less likely, to engage in a suicidal behavior or even die by suicide. So it's a really important thing to know that we are relational creatures, and our veterans especially need that relationship for support. So what do we do in the moment if we have a veteran? So if, again, I'm trying to think about my audience and who may be tuning in. If you're at a particular facility or agency and you come in contact with a veteran, we teach this to all of our VA employees when they come in. There's a program we call Operation SAVE, and this acronym is part of it, and we teach it from physicians to folks that have literally no contact with veterans, engineers to MSAs or support assistants, to nurses and so on. And SAVE stands for this. One, it stands for the signs of suicidal thinking. And just take a moment and think about what might be signs that you might look for. While you're thinking, I'm just going to get a drink of water, but just think about what might be signs of someone thinking about suicide. So after you've thought about that, the next piece here is really about asking the most important question of all. So the ask is asking a very bold and direct statement. If you've got a veteran that's in your facility or agency, or even a friend, that's saying things like, I don't want to be here anymore, I'm just thinking about giving up. You can ask that question if they're going down that path, to ask, are you thinking about ending your life? You can say that in a very calm, really thoughtful way without, you don't have to say you're thinking about killing yourself or you're thinking about suicide. You can say you're thinking about ending your life. You can use those other two examples as well. Um, you don't put the person or the veteran at greater risk by asking the question. In fact, you give them the space to be validated, which is really the V, which is validating the veteran experience. And you're validating their emotions and what they're going through, and you're giving them also the space to feel like they can share their story. When we don't ask the question or we avoid the question, we also leave it for the veteran to keep that to themselves, which also brings about shouldn't say brings about, but at least it leaves that space or that question unanswered, and it leaves that veteran in that more vulnerable place that they're in. The E is encouraging treatment and expedite getting help. So this part, I'm going to get into the resource in just a moment. Before I do that, I just want to go back to what the warning signs are. Some of you are probably thinking about hopelessness, anxiety. I'll add depression to this list, feeling like there's no reason to live, rage or anger. Noticing things like engaging in risky activities. These are things you want to pay attention to. If you've seen escalating substance use occur, where that veteran is drinking or using more than usual, that's something that we want to pay attention to. And then isolation. Withdrawing from others is really important here, that we really want to pay attention to that isolation. So this gets to the E, that expedite, encourage and expediting getting help. So what should I do if I think someone is suicidal? Well, one, we don't want to keep that veteran's behavior, suicidal behavior, secret. We don't want to leave them alone if they've made it known to us. And we want to try to get that person to help, to their doctor, nearest hospital or emergency room if needed, if it's at that level, or may even need to call 911 if it's a more imminent issue. And we want to reassure the veteran, of course, that we're here to support them. If you're not a clinician, if you're not in the mental health world, so to speak, um, and you have an admin role or you're a layman of some sort, and you're like, I don't know how to, I wouldn't know how to assess. No one would ask you to assess in that moment. It's not so much about assessing, but it's more about connecting them. Thinking about it, I often say this to different providers and folks around the VA. Think of it like you're handing the baton off to another person, and they're going to carry the baton. Your job is, you learned about this high-risk behavior, um, the veteran sharing suicidal concerns with you, and your job meaning I'm going to connect this veteran to help. And so reassuring that that help is there for them. Not trying to be judgmental, just letting them know that you're there and that you want to get them connected to a professional. And one way to do that outside of 911, of course, if it's a veteran is just struggling, going through, a crisis or mental health concerns, then making sure that they get connected to the Veteran Crisis Line is really important. That number is 1-800-273-8255. And for veterans, you want to press 1. Now, keep in mind, you can call as a third party. If you're a friend, loved one, a person working with the veteran in the community, you can call on behalf of the veteran as a third party, partly because you're trying to connect them to support. The VCO will reach out to that veteran and work to get in contact with that veteran. And if emergency services needed, they'll deploy emergency services to reach the veteran. Just a statistic around this, there's been approximately well over 100, I think it's around 120, 30,000 or more rescue attempts have been made since the Veteran Crisis Line was developed in the last 13 years or 13, 14 years. That's an amazing number of veteran lives that have been saved because of the Veteran Crisis Line. Just so you know, you can also use the chat there below, the veterancrisisline.net. It's another way to initiate contact with the Veteran Crisis Line. So those are some roles that you play in your respective agency, community, in helping veterans. I often get this question from different folks around the VA and even in the community is, what do I do if that veteran is not with me, or we're not on the phone, but it's in social media? It's really the same process. A veteran making a comment on Facebook that is concerning to you, or you're concerned about their general welfare or their mental health, whether it be Facebook, Instagram, any kind of social media platform, then offer the veteran crisis line to them. Let them know that help is there for them to get support. So let's talk just for a moment, as we start to get on the home stretch here, just about what it means to mitigate risk. And whether it be working in the community or in the VA, we want to look at different strategies to mitigate risk to our more vulnerable population. So if you think about our homeless population, they already have risk factors because, one, they're homeless. In most cases, our homeless population may have either a substance use or mental health concern, or possibly even both. So they have multiple risk factors that already put them at risk for suicide. Again, doesn't mean that they're going to engage in a suicidal behavior, but we already know they have heightened risk. And so we want to help mitigate risk in their situation as well. We began to talk about lethal means reduction earlier. We just talked about connecting veterans to care. We also want to use things like safe messaging, and why this is really important. When I think about shelters or other programs that work with and partner with veterans themselves, if a veteran dies by suicide, we want to make sure that we send out real safe messaging around that. And I'll share a clip or a slide about that in a moment too, and explain more about what safe messaging means. Furthering the campaign of #BeThere, the importance of having a significant person in that veteran's life. That helps mitigate risk. And then, of course, connecting the veteran to the community and other resources that may be beneficial to that veteran. Those are all mitigating or mitigation strategies. And why does lethal means reduction, like, for instance, why does this work? What do we know about it, and how does lethal means reduction play a role? Well, we do know, before I get into this slide, we do know that that when a veteran, or any civilian for that matter, has a plan to die by suicide one way, if it becomes more difficult to have access to that means, in most cases, they will not choose another method. Now, again, in general, that's the case with research. There are outliers to that. There are cases where maybe an individual, and statistically would show that there are a smaller number of cases where an individual will not have access in one way and will find another way. But the vast majority, when they don't have that preferred method that they were planning on engaging in, will not result in dying through another means. And how do we know this? I'm going to give you, there's all kinds of examples with this, but here's two for you. In 1998, after the UK, they introduced legislation around restricting the pack sizes for acetaminophen. What they noticed was they had a significant reduction in deaths due to acetaminophen overdose. And that was noted during the 11 years following the legislation. So what they found is that became a promising suicide prevention strategy. It reduced their risk for suicide. The UK had the same thing around their heating mechanism with gas and coal. Gas being a preferred method around, this was around World War II time, when they switched out of that methane gas. I forgot the name of the type of gas they were using at the time. But they were, inhaling that and dying by poisoning in their homes that way during the World War II time period. But after they switched that to a different type of heating mechanism, which I believe switched to coal, they had a drastic reduction in suicides. The last bullet point highlights really jumping, from high locations like that were popular, like you may have heard about the Golden Gate Bridge. There's also a bridge in Washington State. And what they found was they restricted access to these suicide hotspots by putting in physical barriers. So wherever we can think about even our respective programs or locations to limit things on our grounds, thinking about different different barriers that could be risky, or excuse me, different areas that could be risky, and having physical barriers put up to limit those vulnerable places. Those all can reduce risk. So for a moment, let's talk about firearms and other lethal means safety here. So one, with firearms, the offsite storage. So when that dialogue begins with a veteran and talking about, again, we're talking about a more vulnerable veteran, and actually this discussion can really um, occur on a more generalized method with any veteran, but especially among our more vulnerable population when they do have firearms and they're in more vulnerable states. Um, is talking about, in those vulnerable situations, who it could be a safe place to store that weapon. That could be a friend or a relative. In some cases, it can be the police department. I've checked around on this in gun stores in Hawaii. This is a little bit more tricky, and there's some barriers to that. I hope that we can move around that at some point locally. Um, and then also gun locks. So some veterans are going to say absolutely not. I'm not going to be willing to store my firearm because maybe protection is really important to them in their home. And but there are other things we can do in the home to help mitigate risk in these situations. One is providing gun locks. We have a multitude of gun locks in the VA that our program gives out to pharmacy and partnering agencies. And we will gladly, if you contact me, we'll gladly provide you with gun locks that are directly to our veterans so that they can have this as a mechanism as well. If you don't know what a gun lock is, it looks a lot like a bike lock. You pull out the chamber, the magazine, I should say, and stick it right through, clamp it. There's a key to it. Obviously, having that key with a loved one, this creates the time period that we're talking about. Doesn't mean that a veteran, if it was that key was with the wife and she hid it somewhere, doesn't mean they can't get it, but it's the time to think through the situation and making it a little bit more difficult. Just having more separation time to consider different options in the moment is really critical and shows to be a reduction in risk of suicide. In terms of lethal means safety around medication, we talked about the blister packaging, the medication disposable kits as well. And then limiting supply to shortest necessary. So for more vulnerable veterans that may have certain diagnoses, certain issues with pain, when they're at a more vulnerable place, limiting that supply, where instead of maybe getting a month's supply, they may get a week's supply. This means a little more work by the VA and the veteran, and our healthcare systems in general, but it's another proven strategy that reduces risk. Going back to that safe messaging that we were talking about earlier, this is really important when we learn about suicides in our community, whether it be connected to an agency or a community program. Um, we really want to use best practices when we're providing information to the news. And so part of that is just being informative without being sensationalistic. We don't want to turn this into a romance over suicide, or make it look as though there was some heroic issues around it. Because when we do, we sort of glamorize suicide, and that's the number two part. We want to avoid that, avoid detailing the methods of suicide and glamorizing this, because suicides in general have a clustering effect. Um, and when a veteran hears about, and they may not even know the fellow veteran, but when they hear about a fellow veteran dying of suicide, I have a veteran on my team, and it just, and we've talked about this, it produces a lot of pain. And we want to make sure that when we communicate, if we're in the situation and reporting in some way, that we want to give very specific but non-sensationalistic kind of information, inform, what happened without detailing those methods that occurred, and keeping it very, well, I shouldn't use the word specific. It's more, the better word would have been to be almost vague about it, not giving a lot of details of all the circumstances that occurred leading up to that event, but just keeping it very succinct. So a few safe messaging resources for you all. I'll let you just kind of browse over them. There's a safe reporting on suicide.org or reporting on suicide.org, the Action Alliance framework for successful messaging, suicide awareness, voices of education, safe.org. And then lastly, if you just Google VA suicide prevention and safe messaging, you'll come across this fact sheet. So the VA's got some really good resources around that as well. Just letting you guys take a moment if you're wanting to write something down. I'll do that before we move into the next slide. A few resources as we begin to wrap up here. The Community Provider Toolkit. These are free online trainings for veteran issues, including military culture, health, and for healthcare providers. You can see the website at the bottom there. You can also get CEUs if you are a provider. Coaching into Care is a really great resource, and what it's used for is for a loved one trying to coach or get their loved one into care because they're worried about their well-being. And this Coaching into Care process has got available professionals that will help, free of charge, by the way, to that loved one to help them with strategies on working with them to get that veteran into care. So as we kind of come to a close here, that public health approach or model is really about working within our communities. So who are these folks? These are our universities. These are our churches, our religious organizations. They're the gymnasiums that that our veterans go to, where they do yoga, where they work out, where they take care of their physical health. We looked at spiritual health there, their education, community health groups as well, agencies and nonprofits like some of you all today, I'm sure, our shelters, and in our veteran service organizations. And these just name a few. I was just brainstorming some different partnerships that we have. And this is part of suicide prevention, the VA connecting with our community. And we want to be, we want to keep that partnership building and growing. So that we have resources, because we know, again, the VA can't solve these problems on our own. They're really complicated, or I should say complex issues, and they need not just the resources, but the support piece built in. So I'll just end there with any questions or feedback, and Andy, you can help me out there if you have any questions from our audience.
Yeah, so we one question that we have is kind of for what you were just talking about, or what current partnerships in Hawaii are in place with religious organizations? Do we have any, what kind of outreach is happening in that domain?
Yeah, our chaplain, unfortunately, just her husband was active duty and they PCS'd out. And so this was something her and I were beginning to talk about. I don't know of any specific partnerships that we have currently, but it's something that we want to start looking into with suicide prevention. I was hoping to have some meetings with her, but she left beforehand. So now I know we have a new contracted chaplain, and honestly, it's something we don't have in place at this moment in time, but it's something that I'm very interested in engaging in within our community, because I think that'd be a great resource for connecting our veterans, as well as having that connection with the VA.
And then a follow-up question on that was if that means maybe providing this type of training for clergy at some point in the future. Is that something that?
Absolutely. Yeah, I think I would love to do Operation Save if we can gather a group of individuals in the community with religious organizations. That'd be a great forum for us to carry out. And we would do Operation Save, which is much more detailed on resources and what exactly to do. I gave you the snapshot of that, and there's a full presentation around that.
Great. And you have an offer from Andy Dahlberg to help connect you with some folks on that later.
Taken.
All right. Andy Dahlberg is our homeless program manager here in Hawaii. So. The other question was, one other question we had was, is it possible to get a copy of the PowerPoint? And I consulted with Mark Alexander from the city, our host for this event, and he's going to make all of the PowerPoints available on the website, hopefully shortly after, and he'll send an alert out to everyone.
Andy, if you can put in the chat, one of the things I noticed I didn't put in the presentation was my email.
Okay.
If you can put justin.fienhold@va.gov, so F as in Frank, IENHOLD at va.gov. Then folks that are, if you have a question at a later time that you'd like for me to answer, or if it's connecting because you're a community provider or agency or something along those lines, I'd be glad to get back to you, and if it's appropriate to partner up for our veterans.
All right. Okay. Well, if there are no other questions, it's been great. We really appreciate everyone joining us. Thank you so much, Justin, for the presentation and the great information. We welcome you to go back to the website, pick out your next breakout session, starting, I believe, pretty soon. And then if you wanted to go, I think the original conference webpage, or the original plenary breakout session is still open. You can hang out for a coffee break, I think, there. I'm not sure what's happening in that during the break, but if you want to go check that out, if you have a few minutes. Otherwise, hope to see you all in the next breakout session. Thank you very much.